Good evening, ladies and gentlemen, colleagues and friends. Welcome to another session of our SPG webinar. Thank you so much for joining us this evening, particularly on this topic of reducing implant complications. Joining me this evening are my colleagues and my brain trust, starting from my left side, Dr. Ghada Soliman, Dr. Agnes, Dr. Zoe Potres, and Dr. Johnson Chou. Firstly, apologies from Dr. Tao Trun, who unfortunately is unwell. She couldn't join us this evening, so she sent her apologies. So to stepping in her shoes, we have Dr. Zoe Potres, who's willing to step in on short notice. So thank you so much, Zoe.
Thank you.
And of course, this evening is primarily for you, our referring dentist. On behalf of the entire team, we want to express our sincere appreciation and thank you for your trust in us with your patients, because without your endorsement, we will simply cease to exist. So thank you so much. This evening is, of course, live and interactive, and that means you can send in as many questions as you like to our Ask That Question box. I can see some of you guys have already sent some questions. Thank you. Keep them coming, and I'll try my very best to direct these questions at appropriate times to our panel, and hopefully we can cover all of them. This evening is going to be approximately 2 hours, so if you want a CBD certificate, please do scroll down to the bottom of the screen and to fill out your email address. If you have missed any of our previous webinars, you can access them via either our website, the sydneypg.com.au website, or our YouTube channel. Alternatively, you can take a screenshot and use that QR code, and that will get you directly to past webinars. Just a quick disclaimer as well to cover ourselves. None of the presenters here on this panel have any financial gain. No one's getting paid for doing this. We don't get any money from the sponsors, no products, not even any good discounts other than the usual stuff. So we're here simply expressing our points of view, our personal opinion. So please do consider these information general information only. It is not to be used for case-specific advice. So please do exercise discretion when treatment plan for your patients. Our sponsors this evening includes Nobel Bowel Care and Dynex Sutures. Nobel is a household name, and they've been helping me with the CBD type of events for about more than 15 years, actually. For the last 5 years, Nobel has given me a very unique position to be running an implant program for them, which is what we call the mentorship program, because it has a lot of mentorship, beg your pardon. The intake is once a year, so if anyone is interested in receiving a good implant program, if I may say so, it's not a bad program. It's consisted of 4 modules, each module 3 days, so 12 days in total. And then in between module, there's webinars and those sort of things. But the structured program is 12 days, lots of hands-on. And out of these 4 modules, we cover things quite comprehensively. Module 1 is all about treatment planning. Module 2 is about surgery. Module 3 is on restorative, and Module 4 is on grafting, sinus lift, and forearch, and all that kind of stuff. So a little bit something for everyone. If you have, it's good for people with no implant experience at all to perhaps at an intermediate level. So that's what the program is good for. So if you want to know more about it, you can certainly ask me for more information, or go to that this website or the QR code, beg your pardon, and you can certainly find out more information. Our second sponsor for the evening is Dynex Sutures. They've been around since '74. So if you're looking for a premium suture, handmade sutures, Dynex is an excellent company to choose from. Once again, they don't pay me for saying this, but I do use a variety of their sutures, and they are pretty good. I know recently that Ethicon, I think, has seized cat gut. So for anyone out there that's looking for a gut alternative, chromic gut, plain gut, again, Dynac has some excellent sutures for you to have a look at. For the ones that's joining us this evening, as new to our SPG family, just a little bit about ourselves. Sydney Prosthodontic Group, we're located in Chatswood in Sydney, offering a full range of prosthodontic and surgical services, including surgical implant placement, grafting, all that kind of stuff, particularly with Dr. Tao joining the team. Now, our philosophy as SPG has always been about building long-term relationship with you and your patients, not just with limiting to in the dental sense, but also, I guess, collectively with each other, our suppliers, anyone that we in contact really. It's always been about relationship building, and that means doing the right thing. Our mission at the practice has always been about doing the best in service for you and your patients. For your patients, of course, it's all about quality treatment, and it's also about not taking any shortcuts, taking the easy way out. And for you, we're here to support you to be the best that you can be. Now, whether that means it's CPD like this, or any for your patients, for your personal development, feel free to contact us, and we're here to help you. In fact, if you like, take down my details, my personal mobile number, my personal email address. You can always reach out with any questions, whether it's work-related, patient-related, HR-related, anything. We're always here to help. And if I don't have the answers for you, I'm sure my brain trust here, or even the endo and the perio team that we share the practice with, I'm sure I can find someone that's a lot smarter than I am to give you the answers that you need. So without any further ado, we'll jump right into our topic this evening, which is reducing implant complications. Now, firstly, why do we even discuss it? Because clearly we know that implant treatment could be very successfully used to replace single missing teeth. It could be used to replace a segment, multiple missing teeth. And for the edentulous patient, we could use a larger number of implants to rehabilitate an entire arch or entire mouth using fixed prosthesis. Or in some cases, it could even be using removable based prosthesis, as in, implant overdentures. For the appropriate cases, of course. Another modality could even be using implants and marrying that up with traditional partial dentures. And take this case, for example, it will be pretty challenging to use a conventional removable partial denture. However, with some strategic implants, we're able to provide the patient with something that's a lot more secure without a clasp in the anterior region, and turning something that may be quite difficult into something that's a lot more stable and predictable. So why are we even talking about this, where especially the survival rate of whether it's the implant or at the prosthesis level is so high? 5-year data is looking at the high 90s. In fact, recently there are some 15-year data that's showing somewhere between 90 to 95% survival. Well, one main reason is because we do see failures and we do see complications. This is even the 5-year data on single implant crowns, where the aesthetic complication rate is around 6%, biological complication rate sitting around 7%, which include peri-implant mucositis or peri-implantitis. It also involves prosthetic complication, where here's the big one. It could be somewhere around 16%, or actually even higher, as reported in some other studies, which include a wide range of whether it's porcelain fractures, screw loosenings, abutment screw fractures. So, when we look at these, going back to the slide, if we look at adding up all the complication rates together of aesthetic, biological, prosthetic, in total, you're looking at getting close to 30% complications. That's just in a matter of 5 years' time for single implant crowns. And that's quite concerning. It's particularly if you're doing a lot of implants, and certainly that's not good for our patients. So I guess tonight's webinar is really aimed at looking in depth of what is the cause of some of these aesthetic complications and what can we do to prevent it. So starting from aesthetic complications, Agnes, could you guide us through why aesthetic complications like this can happen and what can we do about it?
Okay, thank you, Ben. So aesthetic complications related to implant, and in particular in this picture here, single tooth implant, it's not just restricted to the notion that your indirect prosthesis is perhaps made of ceramic, and over the course of time it can have a differential appearance towards the aging dentition nearby. And also, like, aside from dealing with things like recessions and changes around the teeth, as you can see in this particular photo, implant restoration, because they are ankylosed, it can result in the infra-positioning, and often this will give discrepancies towards the zenith harmony, the length of the crown, the disproportionate of the crown form, black triangles, and the list goes on. So why do we get these problems? As you can see here in this diagram, it's because our actual bone, for example, take the maxilla, because it is most prominent in our aesthetic zone. It does grow downwards and forwards, but in effect, if you look at the different little black arrows on the diagram, this is where the bone will grow in that direction across these suture lines, and depends on which paper you may quote, the suture lines along this maxilla does not close until the age of 15 to 18, but in some papers is as old as 20 to 25. So that is one reason, if we want to avoid a very fast rate of seeing this infra-positioning, to defer implant placement in young adults. Perhaps they have lost their anterior tooth from trauma, from different presentations, to after the age of 25 years old. Having said that, it is not a strict expiration date. Have a look at this particular photograph. You can see that aside from the vertical discrepancies, if we look at the occlusal view, you can see the rest of the arch form coming a bit more forward. So it is the splintered implant prosthesis that is lagged behind, because it is now ankylosed to that particular alveolar process and will not move with it. Here you can see with the yellow zenith markers that their discrepancy would cause the disharmony, not just in your prosthesis, but also the location of the natural pink frame, and of course the discrepancy in the incisal edge positions. And along with this would become the disproportionate crown form. There's no longer symmetry between the left and right. In a patient with a low lip line, you may consider changing the prosthesis to disguise this, and it may be relatively easy exercise to make amend. However, you can imagine if this particular scenario is of a patient with a high aesthetic zone, then it will be much more challenging. So as mentioned before, it is not just restricted to a case scenario that is of our younger patient. In our older cohort, it can be observed over a number of years, and it's always cautionary to inform your patient, whether it is anterior zone or in the posterior maxilla, where you may see a little opening of diastemas between teeth as the bone continue to grow over time. And these equally in the posterior segment can cause foot traps as well, and difficulty in the embrasure space. But here I have a case where the patient had the tooth 2-1 replaced with a single tooth implant, and the patient had this procedure done at the age of 43. You can see that 18 years later, when the patient is of the age 61, the discrepancy he presented of this 2-1 is very, very noticeable. And this particular implant, again, it was placed when he was age 43. So the take-home message really is that try to defer cases where possible, especially in a very high aesthetic zone, so that you can avoid very large discrepancy of the infrapositioning from happening. But always inform the patient, so this certainly does not come as a disappointment with a surprise attached.
And what would be the youngest age if a young patient presented and saying seeking implant replacement because of trauma and whatnot? What would that be?
I think first of all you have to empathize with that demand. And you got to look at it holistically in terms of what the patient's concern really is. If they are after a fixed replacement that is meaningful to them for their self-confidence and so forth, and where it is possible, resin bonded bridges can actually be made in a very aesthetic way as an interim. There are certain indications, but not as a default, to even consider maybe using a mini implant temporarily. However, I think there are other means, and when one does embark on especially dealing with, because often it pushes the clinician towards even thinking about doing immediate placements for these cases sometimes, definitely have more cautionary note. And I think to a certain point, just by informing doesn't warrant the green light to proceed. If you do deem that this can become a major complication that maybe the patient cannot comprehend right now, and may say, go ahead despite. I think there are some clinical judgment that is important to at least defer until 21, 23, but preferably 25 plus.
Absolutely.
Yeah.
And as you can see on that case earlier, that doesn't matter what age that you place implants, this risk still can occur. One of the questions from the audience tonight has asked that sometimes when you have adjacent implants in the maxillary anterior region, 1-1, 2-1, or 1-1, 1-2, often we have that flattening of that bony crest, and as a result, there's this dreaded black triangle. So what could we do, I guess, to mask that black triangle? Is it through prosthetic means, as in using pink porcelain by splinting the prosthesis, or is it by surgical means, doing some sort of tissue grafting to try to build up that papilla? What would be your advice here, Agnes?
I think it's a good question, and it comes down to your ability to assess the clinical criteria of trying to see whether or not you can maintain or anticipate for that papilla to fill. For example, you can refer to the ITI guidelines, looking at the SAC protocol, and the particular recommended distance between the adjacent tooth and implant, or if this is implant to implant. Definitely then consider the gingival bile type, the depth of the placement, the distance to the contact area. And of course, you also have, aside from all of these clinical criteria and technicalities, you have to consider the patient's self-care, maintenance, and their dental awareness. Because if you are trying to recreate these pink parts with their biological means, they also have to understand that with time, these things can change, just like the other natural areas of the architecture. Whether they may be aging and have recession and have periodontal aspects towards their overall appearance, with time things can still change and modify. I think in your communications, by distinction at the forefront is that your implant prosthetic is a replacement of their missing tooth, so that they can actually appreciate what you are engineering. And if the patient do have concerns about these prospects of, okay, you recreate this, but in future times it may deteriorate, whether at the forefront they do want to already mask it with a bit of pink porcelain, or they're ready to do this addition later on as required, these can all be by communications. But that can come at the beginning when you assess and plan the case, whether these would be replaced with your pink or with biology.
Yeah, absolutely. And there's a few participants that was wondering, what do we do for that case, for this gentleman? Given his age, we of course gone through a large number of options involving ortho, try to reorganize the occlusal plane, and then replacing the implant prosthesis so at least the incisal edges could match, including plus and minus even some soft tissue grafting to improve the general zenus. But at the end, because of these really highly technically complex plan, and where the implant and the prosthesis and the tooth crown next door is still perfectly sound, he actually elected for no treatment. Moving on from this complication, we're just going to touch based on a biological complication, which is a peri-implant mucositis, because we do see that in quite a large number of patients from time to time. And for the just to set the tone, of course, this is when, similar to gingivitis, where the soft tissue is inflamed with bleeding or probing, but no bone loss. Given its high prevalence, Zoe, could you cover for us what are some of the potential causes and what can we do to reduce that?
Thank you, Ben. So definitely peri-implant mucositis is the inflammation of the soft tissue, of the peri-implant soft tissue. And that usually results from bacterial biofilm accumulation at the implant site, resulting in the balance between the host and the microbe to be out of whack. So the inflammatory process begins. Now, the good thing about peri-implant mucositis, it is a reversible process with careful management, but we have to be also vigilant of its occurrence because it can predispose to peri-implantitis. Now, in terms of diagnosis, when you assess for peri-implant mucositis, there will be generally bleeding on probing, some separation. Radiographically, you should not see any bone loss beyond what has naturally occurred as initial bone remodeling after implant placement. So when we have a look at the reason where people loses their teeth, one of the most common factors is related to poor oral hygiene. And with poor oral hygiene, it can lead to all sort of things. So something that we need to keep in mind when planning for future replacement for that patient. For instance, this lady who may have poor oral hygiene as well. And of course, this has not resulted in that severe she's losing the teeth because of the severe active advanced periodontitis that has resulted. But having a good oral hygiene helps to control our future planning, and we need to educate our patient that the importance of maintaining that for any implant, future implant treatment planning. So when we notice a patient come back for their reviews, and you can see there's a insufficient oral hygiene around the dental implants, this just commonly results in peri-implant mucositis. And this, if not treated, it can result in progression to peri-implantitis. However, with peri-implant mucositis, if we're able to control it and treat it, and generally that might be by mechanical debridement and using ultrasonic scalers, improving patient oral hygiene, maybe airflow, using flosses and brushing, improving the brushing technique, we can help improve the oral hygiene against around these dental implant. and minimize the potential occurrence of any future problem. Now, if we are to look at another factor that may contribute to issues around implants is lack of keratinized mucosa. So keratinized mucosa is important because it dissipates the muscular pull, the frenal pull, and it also protects against movement of the mucosa around the implant. So when there is lack of keratinized mucosa, the tissues is quite fragile, and the patient might find it uncomfortable or painful to clean around the implant, and that can result in accumulation of plaque around this implant. So in this case, where you have the 4-3 and the 3-3 abutments, you can see the 3-3 has gingival recession, there's a high frenal attachment, and there is more plaque accumulation. So one way to manage this is a free gingival graft to help thicken the soft tissue and improve our chances of protecting that implant from further recession. One of the studies, this is a cross-sectional study that was published in the International Journal of Implant Dentistry in 2020 that looked at the association of keratinized mucosa with peri-implant tissue health. And they found that the lack of keratinized mucosa, and when they say lack, they considered anything that is less than 2 millimeters as insufficient keratinized mucosa around the implant. So looking at the comparing the people who had implants that had abundance of keratinized mucosa and others who had non-keratinized mucosa, that they found that the lack of that protective thick zone of tissue around the implant, there's a significant association with issues such as, hard to see there, plaque retention, so people were more susceptible to having more plaque around their implants, as well as increase in more significant association with gingival recession around the implants as well. And the other factor also was bone loss. So there was a significant association with bone loss, and they looked at more than 3 millimeters of bone loss in people with no keratinized mucosa. The other factor that they found was also significantly associated was peri-implantitis. So there was increased incidence of peri-implant mucositis, but peri-implantitis was significantly related to lack of keratinized mucosa. In fact, there was more than a threefold increase in the incidence of peri-implantitis in patients who had non-keratinized mucosa. So leading from that, we know the importance of having a good attached or keratinized mucosa. So this case here, where we have 4-6, 4-7 implants, we can see that there are high frenal attachment, there is mobile tissue. At that stage of treatment, it was elected to have a free gingival graft to help thicken this tissue and provide a firm, more robust tissue around the implant abutment. So using some from the donor side is the palate, and using that free gingival graft to augment the buccal aspect with an apically position flap and slick sutures to stabilize the flap to the healing abutments. And on follow-up, you can see the progression of healing. So we have to follow these patients to ensure that everything is healing well. And then the post-operative or post-prosthetic, you can see that there is a better soft tissue contour that is more firm and more protective for the around the implant restorations.
Thank you so much, Zoe. So having ample keratinized soft tissue is important, and when I graft next time, I'll try to do more than 2 millimeters. Here's a question from the panel, Zoe. It's slightly sort of off tangent, but I thought it's quickly covered here. It's asking that whenever we have bony changes, I assume it's bony recession, bone loss over time after implant placement, are there any subsequent nerve issues? I'm personally not aware of any nerve-related issues.
Nerve-related issues. I'm aware of that, but I know that some tissue around the implant, peri-implant tissue, might become a bit more sensitive.
Yes.
For a period of time, sometimes
like hypersensitized, right?
Hypersensitized, especially if it's lacking keratinized mucosa.
Yes.
I find patients when they eat, possibly they injure that tissue and they come and complain about discomfort, pain. There is nothing else that indicate any other problem, but we always point it out to maybe some sensitive tissues around the implant.
Yes.
I'm not aware of that associated with any other nerve problems.
Yeah, me too.
I think alongside with a patient who may have a chronic pain profile or other, psychological aspects.
Neuropathic pain?
Well, whenever we even do endodontic treatment, like amputate the nerve or anything related to oral surgery, not unique just to dental implants, then there is a very small degree of chance that it can lead to neuropathic conditions. So in regards to the particular nerve pain, to that question, I would caution in that regard. But when the question was more specific to ask, as an osseointegrated implant is taken management and is successful, however, over a period of time, due to the bony changes,
remodeling,
will it cause pain in itself? I think that's not actually documented as a causative process just by the bone changes that is occurring surrounding the implant.
But great question. So thanks for the excellent questions, and keep them coming, guys. Moving on to the next step. As Zoe previously alluded, that peri-implant mucositis, when unmanaged, can take one step further, which is peri-implantitis, and that dreaded peri-implantitis. Ghada, could you cover with us, now moving on to peri-implantitis, what it is, of course, what are the factors that leads to that, and what can we do about it?
Absolutely, Ben. So peri-implantitis is one of the most common complications in implant therapy. And when it occurs, it actually progresses very slowly. So if the patient is lucky, it's because peri-implantitis is asymptomatic, so patients will not seek treatment for pain. But if they're lucky and it gets caught during a review, then it can be managed successfully. And it does not, most of the cases, it does not tend to progress to severe periodontitis. But if it doesn't get caught or gets missed out, it can progress to such a severity that the patient would lose their implants. With peri-implantitis, the radiographic picture, it normally shows a saucer-shaped defect. However, which is a bit different to other causes of bone loss. For example, we could see horizontal defects with overloading due to mechanical factors. However, it can start as horizontal bone loss from mechanical factors, and then it could progress into peri-implantitis. So the literature is very clear about not placing implants in patients with active periodontal disease. It is an absolute contraindication. It is also very clear about periodontal factors' influence on implant failure and success. Periodontal factors include oral hygiene, genetic predisposition, history periodontal disease, possibly systemic conditions like uncontrolled diabetes. In patients with history periodontal disease, they actually have a higher risk of developing peri-implantitis, and it's about an implant failure, with implant failure risk about 1.7 compared to patients with no history of periodontitis. And this number is actually very important to mention to our patients when we're getting their consent, especially if they have such a periodontal underlying factor. And the thing is, with these studies, there's been these implants were placed by a periodontist in patients who have stable periodontal condition. So imagine what would happen if you place those implants in when the patient is struggling with active periodontal disease. So peri-implantitis can happen in all types of implants, all brands and connections. For example, this is a Brannamark external hex, and patient had a history of periodontal disease. It was stable for 5 years, but at 5 years mark, the patient is showing signs of peri-implantitis. This one is internal hex and bone level implant, but still you can see severe peri-implantitis. Even with tissue level implants, they're not immune. And especially in this particular patient, there was no teeth, so there was no active perio. Patient was edentulous, and the clinician who placed the implants was a periodontist. So that tells us that peri-implantitis can happen even if the clinician who placed the implants is very diligent. But in that particular case, the patient has a history of uncontrolled diabetes, and that so it's very, very important to identify those periodontal factors and try to always keep an eye on our patients and to manage quickly and effectively once peri-implantitis develops. Another significant factor is smoking, of course, and patients who smoke have twice the risk of peri-implantitis as compared to the non-smokers. And it's not just about developing peri-implantitis, it's also even during the surgical procedure, because smoking in general reduces microcirculation, reduces angiogenesis, and also increased risk of infection. So if the patient is smoking, they could get failure of their bone grafts, or even failure of the osseointegration. And it's not just about the cigarettes, but also we've got e-cigarettes, which are even worse because they've got this liquid that we have no idea what is it made from. And also there is not many studies who could document the adverse effects of the e-cigarettes because the liquid is non-standardized. So this is the case where the patient was a smoker, and at the consultation he promised that he's gonna quit smoking, and he did, and the implants were placed in a two-stage approach. And at the second stage, the clinician found out that there is exposure of the cover screws, which indicated bone loss. So upon further discussion with the patient, he admitted that he went back to smoking. And as you could see, there is horizontal bone loss, and this is due to reduced microcirculation at the time of the healing of the implant. Another factor that I would like to mention, which could influence bone loss early on, which is the thickness of the gingival tissues, in particular in areas where we have inherently thin gingival tissues, like the posterior mandible, for example. And we all know about the or we heard about the biologic width for natural teeth, where we've got at least 3 to 4 millimeter of soft tissue crestal to the alveolar bone. We have a similar phenomena in implants that is called PSTA, which is peri-implant supracrestal tissue attachment. So the implant is the same, one way or another, the body would want to have 3 to 4 millimeter of soft tissue crestal to the peri-implant bone. So for example, if you have a case where you have the soft tissue around 2 millimeters, similar to picture number 2, and you place the implant conventionally, like a crestal or a little bit subcrestal, and you do not consider thickening of the soft tissue at the time of surgery, almost certainly you will get at least 2 millimeter bone loss. and exposure of the implant threads, because the body would want to re-establish the PSTA. So in this particular case, you could either consider soft tissue grafting to thicken the gingival tissues at the time of surgery or after the surgery, or you also consider deeper placement of an implant, possibly by 2 millimeter, if that's clinically applicable. So even if you lose a little bit of bone to re-establish the PSTA, the implant will still be enveloped within bone, and you will not get thread exposure.
Yeah, thank you so much, Ghada. I mean, this concept, this PSTA concept, is only something I learned over the last 5 years. So I'm pretty late in my implant game to learn about these things. But that's, I guess, what these webinars is all about, is to constantly share information so that we can all improve in the best interest of our patients. We do have a question on smokers, Ghada, and one question is about, for smokers that are seeking implant treatments, do you tell them to stop smoking before surgery? Is there a protocol that you usually go to? How do you go about talking about smoking as a risk factor for patients in general?
So I do explain the risk, stating numbers, and we do not proceed with implant placement for a patient who is smoking. I do not, personally. I did get some patients who were smoking long term, and with a little bit of support, motivation, because we see those patients for a long period of time. It was bigger cases, and they did manage to quit. So I don't give up on my patients. There's also a lot of programs out there that help quitting, but sometimes having a beautiful smile or good function could be a good motivation, but it's a case-by-case basis. It depends on your rapport with patients. Sometimes you develop that rapport and that trust, and they want to prove that they to themselves, not just to you, to themselves, that you could do it. So some patients have that personality, and I've seen it. And I have patients who placed implants for I would say maybe 5-6 years ago, and they quit smoking, and I see them for reviews and they quit smoking, and some have gone back. And once I know up, they come back. This one case just a couple of weeks ago, he's seeing him. So, but I also take photos actually, and show them the changes, the soft tissue, the staining. Because once I saw his teeth, I said, you went back to smoke. So how did you know? I said, it's on your lips, it's on your gingiva, it's on your tongue. So I promise I'll stop. But it's a case-by-case basis. But I wouldn't, like that particular patient, he stopped smoking before we placed the implants. But I would never ever place an implant for a patient who is smoking, and never.
Yeah,
and it should be at least 6 months from stopping smoking, not even before. Yeah.
A lot of literatures are promoting somewhere between as short as 2 weeks to 1 month prior to surgery. Obviously, depending on the complexity of the surgery, the size of the wound, what is the procedure doing, healing of the patient. That's 6 months seems to be.
I have to trust them. I know it's not evidence based, but it's trust.
I think there's a difference here, whether you're just simply stopping smoking for the fitness of the implant surgical procedure, and whether you are aiming for it to be able to osseointegrate without complication, early complication, versus the ongoing impact of smoking. And I think we do have to be realistic. For example, if there are smokers that, are true, possibly addiction-related smoking, or combination with their depression or anxiety or mental health profile, that you encourage the smoking cessation, but you also would direct them to work with their GP or their the mental health team, because as they change their smoking dosages, it can also influence their medication. And of course, if we are looking at the long term, it's not just the peri-implantitis, but perhaps any of those parafunction aspect. But it all comes back down to the ownership of how they may take care as they make these choices for the rehabilitation overall. So I think that's the fundamental difference between just stopping smoking at least for 2 weeks for the fitness of the surgery versus if we are looking at promoting the long-term health. Yeah.
No, thank you, Agnes. And then also just to clarify, because there's some questions about, how much, going back to the concept of the PST, how much tissue, soft tissue do we actually then need in able to have stable implant? It's not, we're not, or literature is not saying that you have to have, whether it's 1, 2, 3, or 4 millimeters. It's a combination of soft tissue and hard tissue. That is above your implant shoulder. So for example, if your soft tissue is only 1 millimeter, because sometimes that's all you get. Now, of course, you could do perhaps some other surgical procedures, some sort of grafting procedures to increase your tissue thickness. But in the absence of doing that, then perhaps you should consider placing that implant getting close to 3 millimeters subcrestally. That's assuming that it is appropriate to do so and it's safe to do so, so that you can have that a total of 4 millimeters of tissue above your implant. Hopefully that clarifies things for us. So thank you, Ghada. Excellent coverage of those patient or biological related factors. So, and just to contributing to the topic of peri-implantitis, sometimes there are not just biologically or patient related factors, but there could even be prosthetically related factors. Now, Johnson, could you share with us what some of these factors could be? I guess is what not to do.
Thank you, Ben. Improper prosthetic design can result in I'll change slide, in patients' access to oral hygiene. So for full arch cases, if you have a concave intaglio surface, then it's impossible for the patient to clean. For the full arch cases, if you look at the picture on the right, it's most important for the surface to be convex. It's already very difficult for the patient to clean a full arch prosthesis as it is. On top of that, it's important to create next adjacent to the implants V-shaped notches to allow interdental brush access. So the picture on the left is a little bit too concave, so it's very difficult for the patient to clean. Just the water flows alone is not enough to clean. Sometimes the prostheses are designed with a bit of a ridge lap, and this can be caused by the implant being placed not deep enough or too palatal or a combination of both. So the ridge lap is to cover the metal exposure potentially. So ideally, if you look at the picture on the right, implant shoulder should be placed 3 to 5 millimeters from the gingival zenith. The picture on the left is a result of a poor planing. The implant shoulder was placed too superficial. For the posterior implant crown, sometimes inexperienced technician may give you a more mushroom-like implant crown. This patient always complained that she can smell something funny in the mouth since it was done. And after removal, you can see it's impossible to clean. So we designed a better, more cleansable implant crown for her. One other issue is the prosthetic emergence profile angle. In this Beagle dog study, they did abutment of 20, 40, 60, 80 degrees. So basically, the higher the degree, it's more difficult to clean. And after 24 weeks of healing, they did histology. Anything more than 40 degrees, they have inflammatory cell infiltration. This is an interesting one. This is a narrative review where they share also a case where the implant was done in 2020. After 4 years, they start to get mesial bone loss, and then they change the abutment. So basically, the new abutment is taller. Some literature, some research suggests you need to have a 2 millimeter taller abutment so that you have a better emergence profile. So if we compare to the initial one that is probably about 0.5 millimeter, it's very difficult to develop your emergence angle. And then what's interesting in this case is they do regain the bone. While this is, not common, so the best way is to prevent it. There's no certain guideline on, what angle is the, is too much, because there's a lot of variables, but to go gentle on your emergence profile angle design. And this is why with the new Nobel Biocare restorative range, they have the more narrow healing abutment, and then they have the same impression core pin, and then temporary abutment, definitive abutment, multi-unit abutment, to follow the same principle. The idea is to give you more space for the soft tissue and more space for the hard tissue, and then decrease your risk of peri-mucositis and peri-implantitis. With the prosthesis design, we try many different things with our ceramics over the years, including very detailed description, including sending X-ray of the healing with a healing abutment for them to copy the emergence profile. But nothing works better than getting them to send us the design to ensure you have the right emergence. It's not too wide, so it's very difficult to fit the prosthesis in, or too narrow. And then after we have the final check, rarely do they get it wrong, and then we have issues because we already have our tick of approval before proceeding. That could be difficult for the interdental brush to get into. So always make sure there's room for the interdental brush, but also it's important to show the patient you can bend it, you can go at a different angle, and then issue them with a correct color interdental brush to make sure they get on top of things. And with the cement retained prosthesis, traditionally before angulated screw, this is very helpful. With the case on the right hand side, where if you go for screw access, it would go through your incisor edge. There are many other factors where some clinicians prefer cement retain versus screw retain. But the biggest problem is you have excess cement, despite best interest, especially the more sustainable the prosthesis is, the more risk of cement retain. This case was shared by our referral dentist. No cement was clearly visible, but soon after, the implant lost a lot of bone, and unfortunately, the implant cannot be saved. The marginal misfit doesn't come from fabrication, but in subgingival cases, it's not uncommon when you sit the prosthesis, you have incomplete sitting, and you have this marginal misfit. It's also difficult to retrieve, so sometimes some patients get a little bit of foot debris caught underneath the implant prosthesis. With screw retained prosthesis, it's very easy just to remove the implant prosthesis and clean everything out, and then put the implant prosthesis back. Or for sometimes in multi-unit cases, you get hyperplasia of the gingiva, so you just remove the prosthesis and then create more room for the pixels. And it's very straightforward. Whereas for this case, it's cement retained, was done overseas. There's a severe peri-implantitis. Even to remove the prosthesis, it took me 5 hours, 35 brand new burrs to carefully cut off the non-precious framework. So generally, we do not recommend cement retained implant prosthesis. With nowadays, the angulated screw can correct up to 25, some brands even correct up to 35 degrees, and then you can always have your lingual access as well.
Thank you, Johnson. Certainly, there's lots of things that we shouldn't do when it comes to prosthetic design. There's a great question from our audience, which include, for whenever you have adjacent implants,
Yes.
you have the choice of splinting them
Yep.
or keeping them separated.
Yep.
And if you choose to splint them, would that increase the risk for peri-implantitis?
I mean, if you look at the periodontist point of view, patients are always under care. They always use the pixters anyway. And even with adjacent implants, the idea is to use the pixters. So if you can have a pixter use, I mean, splinting them doesn't really increase the risk. But per se, yeah. But if the patient doesn't have good oral hygiene, then
Yes.
Then the idea is to improve the
Yes.
oral hygiene first.
For sure.
I mean, rarely do you see the risk is so high, then you do them as an individual.
Yes.
If you think the risk is high, then should you place the implants, or do you put them as a individual?
Yes.
But if they are too close together, then splinting them will be difficult to allow pixter access. Then do
Absolutely.
you do them individually? So it's
Absolutely.
case by case.
Yes.
So mostly I would split them, but
Yes.
other in very odd cases. Yeah.
Absolutely. I think if this question was asked to a group of periodontists,
Yes.
I think equivocally they'll say, of course, don't split them, keep them separated. But when you ask a group of prosthodontists, often our views do differ, because a periodontist, primarily their patients suffer from periodontitis, so they want the best possible cleansable prosthesis, whereas a group of prosthodontists, often we get the severe bruxis.
Yep.
So we feel that there's definitely a clear mechanical advantage of splinting a prosthesis, as long as cleansable, easily cleansable by using interdental cleaning devices.
Yep.
That's, I guess, where our thought process lies, and how to reduce a risk of mechanical overloading.
Yes.
So now that we've covered a whole host of biological, patient-related, and prosthetic-related factors, I also wanted to quickly cover another potentially type of factor, which is when you look at these pictures, clearly we say, aha, well, that's we can see thread exposure on all of these implants, so therefore that is peri-implantitis. But when we examine on closer detail, all of these patients has almost always excellent oral hygiene, and potentially when you probe around these implants, there probably is not that much bleeding on probing, but yet the amount of bone loss is significant. And one of the main reasons for that is because that anatomically in these CBCT studies that they found that the buccal plate, particularly of the anterior dentition, is so thin. It's in very few cases actually greater than 0.5 millimeters. And most of that thin bone is all bundle bone, meaning that as soon as you take that tooth out, well, it doesn't matter how good your ridge preservation is, quite likely you're going to get some bone loss. So when you're placing implants in these thin bony regions, sometimes you have very thin bone, buccal plate. Sometimes there's thread exposure. And if a clinician decides to just simply finish the surgery there and accepting a thin buccal bone, well, over time, that buccal plate can simply resorb, resulting in thread exposure. And in thin gingival cases, well, that implant is even showing through. And if you were to take a CBCT, it could look something like that. So there's a very interesting study that looked at this very phenomenon, which is what is the thickness of the buccal plate at the time of implant placement. And what they found is that if your buccal plate is greater than 1.5 millimeters, which is that blue line, now over time in the course of the 3-year follow-up they did, they found the clinical crown height is getting shorter. And what that means is that the soft tissue is actually growing. And that's why the clinical crown height is actually getting shorter. Whereas if your buccal bone thickness is somewhere between 0.5 to 1.5 millimeters, which is that green line, then your clinical crown height has increased a little bit by about 0.6 millimeters in 3 years' time, meaning that the little bit of gingival recession by about 0.6 millimeters has occurred. And if your buccal plate is less than 0.5 millimeters thick, then that's the yellow line. So now we're going to get some significant gingival recession. In other words, bone has shrank and the soft tissue has simply followed. So very common in these cases of thin bone. I think I guess my take-home message here is that learn to graft. It's not easy, but it is not impossible either. Have developed plenty of bony thickness so that when you place your implant, there's at least 1.5 millimeters bone in the buccal and the palatal side to give you that stability, so that in the long term you have a great outcome. If you happen to grow too much bone, that's always a great problem. It's never a bad problem when you have too much bone. Another aspect to look into is not just buccal palatally, but also laterally mesiodistally. There is a minimum safety distance that we should consider whenever we're planning for implant therapy, and that distance is 1.5 millimeters between your implant to the natural tooth next door. And that distance, what we're talking about, is that from the crestal level or from the apical level. It's not necessarily we're talking about at the coronal level. So take this case here, for example. This is Claire. She's a young lady and she's been having a congenitally missing canine. So she's been wearing a Valplast denture for quite some time. She's now in her late 20s and she really wants to have a fixed prosthesis. So we can see straight away that coronal width, it's very, very narrow. But when we take a calibrated PA, when we do our measurement, we could see that at the crestal level and the apical level, it is equal or greater than 6.5 millimeters. And given that our narrow implant in this case was done about 15 years ago when I first started in practice, so this was a narrow platform, Braunemark implant 3.3 millimeters, so I know I have more than 1.5 millimeters of safety distance next door. We did carry out some minor odontoplasty with her consent, so we create a small canine. Now clearly that canine is not symmetrical to the tooth on the other side, but in her mind this was a very, very good result because she doesn't have to wear her denture anymore. We do see cases like this where this clinician has attempted to increase the space using orthodontic treatment, which they appear to have succeeded in doing so. But then they proceeded with placing a narrow implant, and we can see that the safety distance between that implant and the tooth next door doesn't seem to be 1.5 millimeters or greater. And then in their immediate post-pros radiograph, I'm not sure about you guys, but I think I'm seeing some shadowing and some bone loss that's going on. It's a good implant, but perhaps because that implant is placed quite close to the tooth next door, and what happens is that has now encroached into the blood supply into that region. And when you compromise the blood supply, well, that bone and eventually that soft tissue is just not going to stay for the long term. And there's another issue, which is if ever that implant needs to come out via trephining, if ever that needs to be done, well, how are we going to safely trephine out that implant without damaging the tooth next door? So we certainly need to consider these factors whenever we try to snake in an implant in a narrow space. Just because that implant could be physically placed, it doesn't always necessarily mean it's a good idea to do so. And in these narrow spaces, it's actually not that common to find a situation that you can actually place a narrow implant just to replace one single central incisor. It's very rare to find these cases where it just happened to be a fat lower incisor and there's enough space to place a narrow implant. More often or not, it's perhaps two or sometimes even 3 or 4 of these incisors are lost, so we can safely place one implant to have a splintered prosthesis. And certainly something like this is perhaps not such a good idea. And whenever you're talking about implant that's next door to each other, talking about 2 or multiple implants, your safety distance in between the implants is no longer 1.5 millimeters, but doubled 3 millimeters. And remember, guys, that this these numbers, 1.5, 3 millimeter, these are not your optimal numbers. These are your minimum safety numbers. So the greater the distance you have, the better, simply because, once again, we're there to also to preserve the blood supply, which ultimately helps you to maintain your bone and soft tissue. So now that we have covered a number of contributing factors towards a peri-implant mucositis and peri-implantitis, ranging from patient-related factors, biological factors, dentist factors, anatomical factors, mechanical or prosthetic factors. So what happens when you get a patient with peri-implantitis? The first thing that I would recommend, of course, is identification. And then if that implant prosthesis can be removed, as in it's screw retained and it's appropriate to do so, I would recommend removing that prosthesis so that you could investigate a number of things. You could investigate the prosthesis, like the case that Johnson showed, where the design of the prosthesis is concave. There was no way the patient could keep clean. Could there be other prosthetic factors, including what if the prosthesis had a roughened surface? I certainly have seen that before. And what if it was simply because of this food that was trapped, under the soft tissue, and simply by removing the prosthesis, you can suddenly flush out all that gunk. And it's suddenly making probing around your implant so much easier when the prosthesis is not in place. So you can have a better idea in terms of how many maybe millimeters of bone loss has occurred, how bad is the bleeding or suppuration probing, or what is the clinical probing depth. And then you could decide whether you want to carry out management non-surgically or surgically. And for a mild case of peri-implantitis, by definition, that's less than 3 millimeters of bone loss or less than 5 millimeters of clinical probing depth, perhaps you could consider non-surgical management of some sort, most likely under local anesthetic. But if that doesn't respond well, or you have a case where you have a more moderate or even severe peri-implantitis, where there's more than 3 millimeters of bone loss or more than 5 millimeter clinical probing depth, perhaps surgical management will be more appropriate, which means that you're raising the flap, a whole host of mechanical debridement. Unfortunately, there's still no consensus on exactly what is the best way to achieve that mechanical debridement. And most periodontists will simply throw the whole kitchen sink at it with every single tools they have under the sun to try to disinfect that surface, with or without some sort of, whether hard or tissue grafting, whether it's at the time or subsequently, to try to stabilize that condition. Some of the questions asked include, what is the success rate of management of peri-implantitis by periodontists? That number really varies depending on the severity of the case and the condition of the patient. But there are some literatures that vaguely suggest somewhere around about that 70 to 80%, if you just want plug a number out of thin air as an approximate number to go with. During the break, there has been a few questions on the topic of how to remove implant crowns, because sometimes, I guess probably because of that Morse taper or that modified Morse taper design, the internal connection, sometimes it could be quite hard once you loosen the abutment screw, but then your prosthesis just can't come out. Johnson, any particular tips that you could share with our audience on what you could do to make it a bit easier?
Yep. So usually I just use my hand and then try to move buccolingually or even rotate, but it's a more upwards movement, try to remove. And sometimes it requires a bit of a persistence. If that doesn't work, then I get the crown, I try to lean against the neighboring tooth.
So it's almost like an elevator.
Yeah, but be very careful, be very gentle with that. You ensure it's unrestored, it doesn't have any prosthesis, because you can...
We don't want to damage the tooth next door.
The tooth next door, so that is the last resort.
Yes.
But I know there are some instruments with a more softer grip, so you don't damage the porcelain. Just try to move it buccolingually to do that.
For those instruments with those padding.
That's right.
Right, so you can hold on to the prosthesis.
I know people have a suggestion for ankles, where they get the pencil, remove the lead and then try to tap, in a upward direction, try to tap it up.
Wow.
But I have certainly not tried it.
Yes.
Yeah, that's for ankles, which is Yeah,
which is almost
tremendous
which is not
binding.
even designed to come out, isn't it?
Pretty much.
Yeah, so it certainly depends on the brand of the implant, the taper.
Yes.
The greater that taper, the harder it is, of course, for you to take out for sure. There are some implant systems that even have tools for help you to unseat that metal binding process. For example, Nobel implants that we're very aware of. There's that sort of that metal driver that we insert into to unseat any metallic abutments. And another question a follow-on question is that if you were to take these crowns off for cleaning, repairing, etc., do you have to replace the abutment screw every time? Because according to the manufacturer, they always say that that the warranty is null and void or something every time that you crank it down.
Yeah. So generally, if you did the prosthesis yourself, for any regular white platform, I'm comfortable to retighten a number of times, but depending on how you feel when you retighten, obviously every time it increases the risk of fracture. But if it's narrow platform where the abutment screw is quite thin, I would say once or twice is safe. But more than that, it will increase the risk of abutment screw fracture.
Absolutely.
Yeah.
Of course, it also depends on what happened before. Are we talking about a case of a narrow implant in a severe bruxa, where after some years in function and then the abutment screw became loose?
That would replace straight away.
Right? We're a lot more cautious of that than, say, a conventional patient, wide implant, wide platform abutment screw. Those things we know is pretty safe to replace at least a few times.
If due to loosening, then be cautious, just replace
Correct.
straight
So
away.
unfortunately, we can't use a one-size-fit-all concept. But according to that's why, from the manufacturer's point of view, they don't know under what clinical circumstance, and that's why they put a blanket statement to say, well, you shouldn't be cranking on the same abutment screw for more than whatever number of times.
Yeah.
And just to retouch on the topic of peri-implantitis, one question asked: does the diameter of the implant matters when it comes to frequency or incidence of peri-implantitis? I'm certainly not aware of whether a narrower implant could be susceptible to peri-implantitis more often than wide implants, guys.
I think another perspective to look at this question would be if the given the same size prosthesis, if you have to have a smaller implant that were used, and if the emergence or the ridge lapping
It's greater.
It's greater, or it's more difficult to make hygienic, or with the smaller implants, otherwise you have to place much more deeper, etc. But this is with a lot of interpretation and assumption. So, but otherwise, no, I haven't looked at a particular study without these variables. Yeah.
Thank you. Moving on to the next category of complications, which is now mechanically related complications. Typically, we're talking about failures of the implants, because we're beginning to see more and more number of failures, particularly of these smaller implants. Zoe, could you cover with us what some of these causes might be, and what could we do to reduce these from happening?
Sure. Thank you, Ben. Now, with mechanical complications, of course, overloading is one of the main issues that might impact our implant restoration. So this may present itself as a screw loosening, abutment fracture, ceramic fracture, abutment screw fracture. But when the forces, if you remember Wolff's law, where you say the functional forces applied through the implant to the bone will stimulate the bone and lead to the bone becoming a bit more robust and remodels to a denser bone. But when these forces become excessive or pathological in patients who parafunction, then they will lead to a breakdown on that bone and eventual failure of the implant. And in these cases that you can see here, there is they all smaller, maybe narrower implants, restoring a large molar site, so that's more posterior, there's more occlusal load. Perhaps with a cantilever, we'd expect more occlusal load onto that implant. So we have to be mindful of the size of the restoration and the load that the patient could generate. It's not always possible to place a regular size implant. Sometimes the bone anatomy is quite narrow, such as And this and some might think, okay, well, I'll just place a narrower implant and that should be fine. But then we have to think about the position of this restoration and whether we can actually improve the site prior to implant placement. So we know that GBR is quite predictable, even when you try to restore the bone beyond their biological envelope. So making this a new bone by augmentation is not easy, but it can be achieved, and that will provide us with a better site for placing an implant that is more wider and also longer. Sometimes implants can be not just narrow. Some manufacturers offer implants that are quite short as well. So these are a range of implants that are 4 to 5 millimeter long. So they are quite small, and although they might be quite good on the short term, in a specific patients, we don't really know the long-term longevity of these implants, especially in patients who might have some factors that predispose them to higher loading. So this is another DBR case where the doctors, dentists have elected to use a shorter implant. Of course, they are the implants at this point in time. They're functioning. They have been restored with a molar, a large molar side. Now it might be quite well for a number of years, but any breakdown in the any remodeling or breakdown in the bone to implant contact, especially from overloading, will result in earlier failure of that implant. So there are ways to consider the longevity and the long-term outcome before embarking on this. And it might not be possible sometimes if there is some anatomical complexities or limitations. Maybe there's a pathology in the sinus where the ENT find challenging and able to manage. Then in that case, yes, of course, we can opt for a shorter implant. But in this case, there is, as you can see, the sinuses, they don't present any complexities. So doing replacing a shorter implant, there might be another reason for doing that. But what is the longevity of those implants, especially when even when we place an implant that is a regular platform or even wide platform, a longer implant. For example, this case here where you have a 50-year-old healthy, fit patient. He's very active. He's actually triathlon and a dentist as well. So these implants were placed at the 3/6 and 4/6 side. The person wears a regular daily use of splint every night, meticulous oral hygiene, attends regularly the dental checkups, but he does have a heavy occlusal load on the implant, and despite having adjacent teeth with crowns that to balance the forces, he presents about 6 years later with presenting with pain on biting hard things on implant number 36. And I think looking at the assessing the implant carefully and looking at a closer picture of the magnification of the radiograph, there was some radiolucency. He basically managed to break down the bone through parafunction bruxism or daytime clenching. So this implant resulted in being explanted. Now, occlusal load is quite harmful, and we have to make sure that we monitor our patient and educate them about avoidance of daytime clenching, and also utilizing some occlusal splints for nighttime use, even in when the implant is quite robust, like this 5.5 millimeter diameter, 30 millimeter long implant. As a result of the occlusal load, the implant platform has fractured. This is another patient who's been restored with a maxillary overdenture. So this is a removable, reinforced overdenture on the locator abutments, opposed by a mandibular overdenture. Now, he's a person who brucks and clench. Even his normal chewing is quite intense and hard. Every time he presents and you ask him to bite on an articulating paper, he's like, he really goes at it.
Absolutely.
So there's a lot of forces generated. So he came presented with pain on biting again, biting hard things, and he can only mimic it when he starts chewing on that side. And it was quite tricky to realize what was going on in his case, because the peri-implant tissue was healthy, there was no increase in probing depths, but eventually he came back with a broken abutment, screw, and then a fractured implant. Now, although this case was managed by replacement of the implant, redesigning the prosthetic aspect by splinting those implants with a bar to help mitigate this issue, these patients, when they present, we have to look into, before embarking on implant treatment, assess whether their occlusal load is significant, whether there's going to be an issue in the future, maybe placing some more and larger number of implants rather than less in a bruxa, pre-surgical augmentation, sinus lift, so we can utilize a larger implant, maybe a longer implant, to help balance these occlusal loads is probably advisable. And when there is a vertically challenged case where we have a shorter alveolar bone height, a sinus augmentation is possible. So if we have a case where there is more than 4 millimeter of residual bone, perhaps simultaneous implant placement and sinus lift can be quite successful, and that will enable us to place a wider and a longer implant. And in cases where the sinus, the bone level might not be as good, then definitely these cases we can elect for a sinus lift procedure that is independent sinus lift to generate that bone volume. And after 6 months of healing, then we have generated, this is one of Dr. Lee's cases, has generated sufficient amount of bone, the abundance of bones to place a larger and a more robust implant to support a molar side restoration. So this is quite predictable in our hands, and it can provide the patient with a much better longer term prognosis rather than using a shorter implant.
Thank you, Zoe.
Thank you, Ben.
There's been some excellent questions from the audience, including, for example, how do you remove a fractured implant from the jawbone? Well, more often than less, if the implant is already fractured, the only way to get it out is probably by trephine. So it's using a particular type of burr. It's called a trephine burr. It's literally a circular sort of cutting tool, and you literally just carefully cut around the implant with a chosen diameter, and then elevate out that fractured portion, much like how you get rid of a fractured root. Maybe this question for the panel. How often do we see implants that's cracked after loading? In a specialist practice, I think quite often, but how often do you guys see it?
I only saw one last week.
Only saw one last week. Yeah. So in a specialist practice, unfortunately, we do see more and more of these type of complications. Once again, I think it's a combination of the factors that the panel have discussed tonight, and there's some more factors to come. Partly maybe the platform, the diameter of the implant, sometimes it is smaller than ideal. The bite size of the patient. Johnson very soon is going to talk about dental parafunction. Yep. So, or location of the implant, is the posterior, is the most last distal unit, a whole host of factors. But certainly we're seeing more and more of these complications. Hence tonight's webinar. So moving on to the next type of complication, which is, of course, a certain thing that's breaking once again, but largely caused by dental parafunction. And we know that dental parafunction is not as so simple as just a occlusal splint. Johnson, could you tell us more about it and how do we manage this?
Great, thank you, Ben. So when the patient comes in with a mechanical complication, it's important to us and the patient to be private detective. Why is this tooth failing? And then also important to let them know, without identifying the cause, the implant could fail as well. And also, their tooth is the strongest, so nothing is stronger than their tooth, right? So when something fails and I come back, oh, your cheap titanium just broke in my mouth. Hey, if they can break their tooth, they can break almost everything. Sorry. Yep. So slip bruxism, traditionally we use an acrylic occlusal spring. Compliance is a little bit questionable because they can be a little bit too tight, so ensure your technician make it relatively loose. But it's thicker, so most patient compliance for long term is not very good. But we do find the 3D printed nylon is much better, much thinner, and then fitting is usually quite good, so snug but not too tight most of the time. So patient tolerance has a significant increase for the nylon splint. Wet bruxism certainly was not taught at dental school when I went through. So as we can see, this patient, the visitor was he's really bruxing, and then when we do wet lifting, when we stress, we always clench, but it's how much we clench. So it's important during the consultation to pay attention to the patient to, pick up that daytime clenching habit. Sometimes, it could be hard food eating habit, it could be nail biting, any habits, that breaks the prosthesis. A very good friend of mine, I restored a implant crown for him about 15 years ago. He used to come in every year or two to retighten the abutment screw, and about 10 years into it, he has actually worn out the internal hex of the abutment. I thought, oh, this is unusual even at the specialist practice, right? So upon detailed discussion, he loves eating pistachio, especially the unopened one. So then that's when he learned, it's best not to use the implant to do that. So he used the other side and vertical root fracture. So end up to be another dental implant. And another 5 years, everything's good. So it may take 10 years to work out something, but unless we control the causing factor, then things are just going to keep breaking. So, at the prosthetic level, porcelain can chip, right? So usually, when we finish the prosthesis, the patient will ask, can I eat normally? I say, what do you mean normally? Normally means normal fish, meat, vegetable is okay. But anything breaks your teeth can, break the prosthesis as well. Any porcelain chipping, meniscal loosening means, there's dental parafunction that is not controlled. So to pay attention, whether, if you're not wearing a guard, we need to have a guard ready for you. Or in this case, you can have a prosthesis zirconia fracture. At the abutment level, you can have an abutment screw loosening. When the patient comes in with an abutment screw loosening, what I'm interested in is what is causing this abutment screw to loose. The patient was saying, he stopped wearing his occlusal splint about a year ago. I said, yep, you need to, get back onto it. He loves eating nuts. I said, that need to stop. And then if we look at the crown to implant ratio, it's a large molar crown, small diameter, implant. So that risk is always going to be there. He asked me, is it going to loosen again? I said, yes, your risk is much higher. And then if uncontrolled, next happen is you can have abutment screw fracture. And then if uncontrolled, they can have the implant fracture. So, to make sure, it's not about, solving or retightening a loose abutment screw. Is about identifying what is the cause of the abutment screw or the porcelain chipping to ensure you don't have a more severe complications. For the management of a daytime parafunction, there are a few options to discuss with the patient, including, rubber band, writing in their hand, a sticky note. But what I find helpful is for the patient to set alarm in their phone every 5-10 minutes to remind them not to clench during the day. And then management of the sleep bruxism, during consultation, after implant surgery, at the impression taking, just re-emphasize, the need to wear the occlusal splint or have one made. For the patients, that is very compliant wearing the occlusal splint and then making sure, they're not clenching during the day, avoid, hard food eating habit, but they are just really brachyfacial, and then you have really, enlargement of the angle of the mandible, and then even you have exostosis of the bone intraorally. And sometimes you've tried everything and they still are breaking their prosthesis, you could consider, a Botox of the masseter muscles as perhaps the last resort. What that does is, they shows a decrease in your EMG. So in group 1, they did Botox, and after 3 months, they put in saline as a control, but that EMG baseline is still, improved compared to, at the baseline. And then the group 2 is after 3 months, they give them another Botox, and then to maintain the, reduction in EMG. And then it's also, there's also changes in your muscle thickness as well with the use of Botox. That's why for certain cases, after long-term use of Botox can result in a little bit of a muscle atrophy. Of course, the adverse effect of a frequent use of Botox, can result in, 6% decrease in cortical thickness. But there's no, evidence of change in either volume or bone structure. So basically, we only use it for the really, really severe bruxism. Yeah,
for sure. I mean, we certainly have patients that they just break everything. We're talking about titanium, zirconia, multiple times, despite being very compliant with occlusal splint therapy use, and they're trying their best during the day, but they just have these big brachyfacial muscles. They just can't help it with that biting so hard. So what do you do, right? And we do find that Botox on selected patients, reviews are required. We're not saying that every 3 months you just stick this needle in and hope for the best. It is a controlled management of such patients. So a few questions for you, Johnson, while we touch on this subject. One is about occlusal splints. The question here is about all on X, but I guess that same concept can be applied to any other fixed full arch rehabilitation implant rep of some sort. What is your go-to splint? Here is asking whether it's hard or soft hard, so I assume that's a bilaminar material, hard on the outside, soft on the inside. Do you have a go-to material, and why is that?
Well, generally, with most splints works by reducing in, most people cannot clench as hard on a piece of nylon or acrylic compared to their own teeth, right? But the mix, the soft hard, up to 30% can clench harder.
Yes.
Compared to other type of splints.
Or only hard material.
Or only hard material. So generally we only use the hard splint generally, unless they have like all implants, then potentially we could consider a soft and hard splint, but the hard is what we go to most of the time, but depending on the tolerance as well.
Exactly.
So basically nylon is even thinner than the bilaminar splint.
Yes.
Yeah. So, but for patients who can't really tolerate, even wearing ASICs of some sort is better than wearing nothing.
Yes.
I think I have a patient, after years of convincing, finally he got to wear ASICs, and he was getting ceramic powder or porcelain chipping when he woke up in the morning.
Wow.
And then that was the last straw. Say, yep, I've decided to go with that.
Yes.
Yeah.
Yes.
So we try various type of splints. Yeah.
I think it also depends on, like Johnson had said, whether it's all on X fixed, over all on X fixed, or whether it is actually all on X fixed on the upper, and you still have your mandibular natural dentition. Do they actually have mandibular natural lower incisors dentition? Because it kind of does lead into the next segment. You know, because it's not just purely mechanics, it is biomechanics. There are changes in the proprioceptions. Not to say there isn't, but there are differences. So yeah.
You can certainly expand on that, Agnes, in your segment coming up. And one final question for Johnson while we're on this segment, which is removing fractured abutment screws, which I know you love doing.
Unfortunately, I was given no choice, right? No one loves removing fractured abutment screw.
I mean, this is a very simplistic question. How do you remove fractured abutment screws?
Yeah. So there are many different ways of removing abutment screws. One is, you try to ultrasonic out in reverse direction, and then the secondly is if that doesn't work, the manufacturer have what they call a rescue kit. So usually, you try to drill a pin-sized hole,
Tiny little hole,
and then they have the reverse kit to. You drive in reverse to engage in that little hole to reverse it out.
It sounds so easy.
It sounds so easy, but it's very, very difficult when it's so deep. And the deeper it goes, the more difficult it is.
Yeah, and it doesn't always necessarily bind well. It's a variety of issues.
I mean, I always worry when I see fractured abutment screw in my booking. So
yes, I'm sorry, I'm making your stress level higher than unnecessary.
But also the amount of research you need to get into, with a rescue system, everything you still need to pre-order before, the patient comes. Yeah. Yes. So while yes, a lot of times that we are able to remove fractured abutment screw, but that doesn't mean every single case that we can always remove it. So correct.
So it can be unpredictable.
Yes.
Kind of like treatment of peri-implantitis. So moving on, we have now covered, of course, there are parafunction related factors, but there is also occlusally related factors. Agnes, could you take us through what are the occlusal factors and how can we control this better?
Yeah, so hopefully after considering the parafunction and all this risk of overloading, what can something we can actually consider when delivering our rehabilitation to minimize this risk? So if we have a look into the mechanical complication, this picture alone with the porcelain chipping, it tells us a lot. Because the forces does have to go somewhere, and the natural dentition, it usually goes to the weakest link. So if a particular tooth is a little bit more periodontally compromised, you may begin to see increased mobility, fremitus, and in some way or another, this takes the blunt of root or tooth fractures. But in patients where they have very little physiologic mobility, you do not see the fremitus occurring, but they also have very, very dense bone, and I'm sure we've all seen it. They may not present with any issues, maybe a little bit of occlusal trauma, and then they may suddenly come in and they have a fractured tooth. And when you see a fractured porcelain from an implant, I think most of us would naturally assume, well, the implant have no periodontal ligaments. So if we are seeing porcelain fracture, at least we're not getting the screw loosening, or if we don't see the porcelain fracture, we're having a lot of monolithic zirconia crown. Now we see screw loosening or even the screw breaking. So the force just have to go somewhere. So I would highly suggest that when the patient do come in though, you do a little bit of forensics. Are these shearing off just on the buccal? Are they shearing off on the lingual aspect? Is there any mid-occlusive issue? So there's a lot of show and tell just by looking at the particular problem. So as we mentioned that on one aspect in natural dentition, we do have periodontal ligament, so they can act as a bit of a suspension. Whereas in the osseointegrated implant, it is almost like an ankylose. So there's no suspension. I think this is almost like a given. Most dentists will communicate that with the patient. But I think what may be a little bit more lacking is to actually highlight that there is a difference in proprioception. And this is the feedback mechanism. Now, often with just one tooth, there's not much discussion about it because there's still so many other teeth nearby. And there's certainly osseoperception, which is regrouping all the different sensation coming from other teeth, your face, the tone, the alveolus, the TMJ, that give the reloop of the feedback. But what we do need to consider, though, is most of the jaw function, whether it is chewing or speech, it is in the cerebellar activity where there is no high-level control. You'll think about what to say, how to say it, but no one of us really think about where am I moving my jaw or my tongue or my teeth to actually pronounce those words anymore. And equally, you can tell patients be mindful of what you eat or chew. But, if you observe their chewing cycle, even if you give someone who has a very strong, forceful chewing habit, scrambled eggs or mashed potato, you will see every rolling aspect of the masseter coming through, even on the softest food. So while, again, we know in posterior unit, we will tell patient, especially if there's a big change of form, you got to take things slowly to not bite your tongue or your cheek. These mechanisms often should take place regardless so that they can refine their chewing pattern, because the micromotion, I will call it, of your teeth in terms of the vertical movement or the flexural movement physiologically upon your biting together is not just something that is observed in natural dentition. So for those who are into occlusion and into fixed pros rehabilitation, oftentimes you may be familiar with the fact that all the posterior units have firm centric contact, but you'll give a little bit of a long centric or a bit of shim clearance on the anterior units why? Because there's the differential mobility that is naturally in dentition. So if you carry that thought and actually have a look at dental implant as well, there are actually observed in studies that the implant crown has vertical movement as well. This is not a movement that is about the abutment or fixture junction or any disruption of the osseointegration. Let's hope not. But it has been measured that on a maximum clench force that actually is quite low, anywhere that is above 500 newtons, in, say, some soft bone of the maxilla, it can be measured that there is 2 to 3 micron vertical movement of an osseointegrated implant. And this particular movement comes from the surrounding bone plastic deformation that occurs. So it does vary depending on the bone density or how forceful the bone is applied. So having a little bit of background and understanding of what actually do dentists and operators consider when they look at fixed prosthodontics, whether it's implant or non-implant, it then leads to a very general description or prescription by dentists to the laboratory that we often would ask for shim stock clearance, especially if this is a single tooth implant bounded by 2 natural dentition in a posterior unit. And this 12 micron in your average, it's like average values, it works quite well. But you do have to be mindful that as you implement this case to case and as you select your patient, you do have to look at their periodontal vulnerability with the neighboring dentition. Is there any differential mobility that is already present? With or without that implant replacement, are you already noting things like fremitus that is occurring? Because as much as you may engineer your implant occlusion, you do not want to keep compromising the next vulnerable tooth. And that is where you may holistically assess and make the correct recommendation. And in some heavy bruxes, I think I see a question here about whether bruxis would you restore an implant slightly out of occlusion. Well, I would say that for bruxis, often I will prescribe at the laboratory. If it is a severe bruxer or periodontally involved, this is the very distal single implant unit to an arch, where I would expect more TMJ compression as well. Quite often, I wouldn't just ask for shim stock clearance. I might ask for GHM foil or even 40 micron clearance in the laboratory or on the model. What you might find that is static, but intraorally though, very, very important. You don't just want to randomly take things out of occlusion completely or be infra-occluding. What you do want is that we spoke about that automation. So if you refer to Soliman recommendation as well, when you're checking for, and this is for single implant restoration, so it's different for full arch, so I'm just drawing this as an example. You will be asking a patient to be in automation mode, tapping their teeth continuously, quite fast. So they just generate a tap. And you will be wanting a centric hold for all your other natural teeth, and you would want a shim clearance at that kind of automation on to your implant. And when they clench, you clench right down, you have a shim hold. And the reason why you do this is because I don't know if any other operators are there that might spend their time, they thought they've adjusted this implant crown out of occlusion. They may have another talk or something, and then they feel something, and you check again, and suddenly, oh my goodness, why is it that they move around or they change their head position and it's suddenly in the bite again? So that is why this particular diagram illustrates what I just spoke about. But it's not just vertical. We also want to ensure that buccolingually in a posterior unit, you want to give that shallower cuspal incline for that freedom in centric. So there are times where for symmetry, you may recommend an indirect unit to the contralateral tooth. And in this particular case, there are certain good merits about it in terms of helping that longer term differential where you can actually have your shim hold on your natural tooth and a shim clear on your implant tooth. Posteriorly, this illustrates that as you are doing the tapping, you can see particular high points onto your implant crown, which you will begin to adjust. And, you know, at times where you feel that, okay, this is where that implant occlusion needs to be, then you got to broaden your eyes and see, oh, hang on a minute, are the contacts on the 5 a little bit heavier than ideal? What am I going to do about it? In this case, if there's already a crown, that's great. But if, say, this particular tooth actually have a class 2 restoration, even though just a standalone tooth, you may not recommend a crown as yet. But considering the purpose and the occlusal scheme design, you may recommend otherwise or do cuspal coverage. And what else you will notice is that we have a narrow occlusal table to try and reduce that buccal palatal or buccolingual loading as a cantilever effect. And here you can see that by making the buccolingual width a bit slimmer, you would be able to have a bit more favorable mechanical loading, but also in the emergence profile, a little bit more hygienic to keep well as well. Here is a particular photo just to demonstrate where this implant crown would actually emerge from, and that buccolingual width already is very similar to the neighboring premolar. And ideally, you may envision, for that particular molar size, it will be this yellow outline. But what we actually want to generate is something that's more like this red outline, that is the fish mouth. Having said that, that is that full buccolingual profile. I do not recommend that you just completely make it flat, because then when you take things completely out of infra-occlusion and not considering the holistic function of the jaw, what then happens is, unless you do have other retainers or splints or other things that stabilize the occlusion vertically. We're talking about the inter-arch stability. Otherwise, things may passively erupt, and they may erupt into a position or an occlusion that is not to your favor. So in essence, what we do still want is, you can see the red dots that are still there in terms of for your centric contact. And it's very important, as shallow as this may seem, it still has that buccal roll profile that is very similar to the neighboring teeth. And here it is again, just to illustrate what we're referring to when we say a more flat-ish anatomy and cuspal design doesn't necessarily mean as a completely flat tabletop. So from this particular angle, often I do encourage people just to look down that buccal corridor, because even on the particular model here, you can see that comparing to the neighboring teeth, that buccal cusp tip is a little bit more sharper, and it just needs to be shallowed out somewhat, but just by a little bit, not significantly a lot. And the best type of burr to adjust these without actually just flattening down would be more like a football type burr, just to open that functional angle a little bit. So a lot spoken about the vertical contact, or as we are looking at the working side contact. One thing not to forget is not all patients are perfect. As you take a glance through, your crown looks good, but you should always check the medial obtrusive interference or high spot, because quite often, like I say, if the implant originally coming in was with that degree of fracture, it could be related to the opposing tooth. So whether you choose to do a little bit of occlusal adjustment or adjust your crown or other means, these are parameters that you still have to look out for. So finally, when we are talking about these aspects, we do want mutually protected occlusion most of the time, which means our anterior or canine guidance can help provide relief from any lateral forces onto our implants unit in the posterior segment. The only exception would be is that when we are replacing our implant, our tooth as being a canine, where now we have a single tooth implant canine, and in these instances we do want it to share a light load in grip function together with the other dentitions. So here you can see that it shares a similar blunted functional angle compared to the contralateral side, but more importantly, when the patient clenches and push to the side, under clench, it still just have a little bit of clearance, because in the end of the day, it's a very interesting aspect when we've spent a lot of time talking about parafunctional load. So things that the basic oral physiology that people don't often talk about enough, I feel, as they talk about implant rehabilitation, is to actually just take note that your average value chewing forces can actually range from anywhere between 50 newtons to 150 newtons on your average person, a person without moderate to severe parafunctions. And this equates to roughly about 10 to 15% of the maximum voluntary contraction of the masseter. And this is in their consciousness. So that measures usually is up to about 400 newtons. We all know that when people are in their subconscious, and this includes chewing habits, it can be higher. And in the nighttime parafunction, values have been recorded more than 1,000 newtons. And that's actually more than 100 kilograms, if you think kilogram newtons, roughly divided by 10. In chronic bruxis, so talking about people with very, very strong muscles, where you observe their gait and they already have a very tight freeway space because their muscles are just chronically already contracted, they actually have a maximum voluntary contraction that is not painful to them. This is just how they can forcefully put their jaw together in their wakefulness, in the order of 600 to 900 newtons, so 60 to 90 kilogram force. So 10% of that, if they're in automation to be using to function, is a lot higher than your normal patient. And that is why I think if you do have a patient coming in with recurring and ongoing infirmities or tooth fractures or occlusal issues, there is an important to discuss these parameters rather than forever adjusting the prosthesis design and somewhat.
That's it.
That's it.
No, thank you so much for covering that, Agnes. And we're coming to our final complication, but a rather common one for mechanical complication, which is abutment screw loosening. A number of our audience has asked questions tonight in regards to this very topic. So in addition to what we've already spoken regarding what Johnson spoken about the dental parafunction aspect that can increase abutment screw loosening, what Agnes said in terms of occlusion control, but there are some other aspects too. Ghada, could you cover with us what maybe some of these other aspects might be?
Thanks, Ben. Well, abutment screw loosening is actually one of the most common mechanical complications in implant dentistry. And when this happens, the red siren should really go off, because the implant system is made in a way that it does not allow such occurrences. So we should really look into the reason behind it, which is most possibly would be mechanical overloading, as mentioned by Johnson and Agnes, because if we just tighten the screw, and if that happens and keeps happening again, and we keep retightening the screw because it's pretty simple, then in the future we might encounter even more complex situations like fracture of the abutment screw, fracture of the abutments or the implant, and even loss of the implant through loss of osteointegration. So it's extremely important to try and find out the reason behind it, investigate with the patient, and manage these mechanical challenges. Actually, the most common cause of abutment screw loosening is a tight interproximal contact, because the implant crown is not like a tooth crown. So when you're issuing a tooth crown that could have or might have a tight contact with the adjacent teeth, if you apply a little bit of pressure, there will be some movement because of all the teeth have periodontal ligament, which will act as a cushion. And if you pressure a little bit more, you would be able to completely seat your crown as you're cementing, even if you had a slight tight contact. But that's quite different when it comes to implant crowns, because as we all know, the implants have ankylotic nature, so they do not move. So if you have a tight contact, it will be holding your implant from totally having a proper fit it will prevent your implant crown from fitting properly onto the implant. And as you're torquing, you will have torque reduction, and that's why the abutment screw would get loose in the future. So before you attempt trying in or issuing your implant crown, you need to check the interproximal contact using a dental floss, and it should feel like as if you're flossing natural teeth. And in addition to that, you also need to check that your model is sound. Like for example, that model, we can see that the interproximal contact is not damaged. Well, in this case, we could see a minor damage, and if you check with your dental floss and find that you've got a good contact or a tight contact, that means in reality the implant crown would be tightly fitting with the adjacent teeth, and you might need to do some adjustments before you try in or issue. So in this particular case, there is a lot of damage And if you find something like that and you try with the dental floss to check the contacts and you still feel that there's a good fit, that means that the implant crown would be too tight, and in that case I would discourage even trying the implant crown, because if you do, and even if you try to adjust the contact, you might be applying extra force, which could cause a stripping of your abutment screw, or sometimes it could cause stripping of your implant. So in that particular case, you would need to take in your impressions and everything to the lab and get the lab to adjust it. So first of all, when we're trying for our implant crowns, we check the tightness of the contact, but the other thing is also to have a feel of the abutment screw as you torque it, or as you tighten it with a screwdriver. So it should feel like the abutment screw or the implant crown is loose as you tighten, except for the maybe last half turn when you feel that your abutment screw is coming to a sudden stop. That means that the implant crown has got a passive fit on your implant, and that you have appropriate interproximal contacts. But if you feel as you're tightening the screw that it is gradually tightening, that means that you would have a premature or a tight interproximal contact somewhere. So in this case, you would of course check with a dental floss, but also you could also use an articulating paper to try and mark the interfering area. And then you could adjust it with a fine grit diamond burr under a lot of irrigation. And after you finish adjusting, you need to try it in the patient's mouth, feeling for both an appropriate feel for the dental floss, that you've got a nice tight contact, and that your abutment screw is coming to a sudden stop. And of course, you would need to polish, because if you don't, you get a lot of plaque build up on the rough surface. You could use some polishes, ceramic polishes, ranging from coarse to medium to fine. You could also use the twist wheels, but at the end you would have to polish the surface to a really high shine. And now you're ready to torque your implant using the appropriate torque driver or implant driver. And now you're 100% sure that you're applying torque at the correct tightness. And in this case, you are less likely to have abutment screw loosening in the future.
Fantastic. Thank you so much, Ghada. So we're coming to the end of our evening, and there's one very interesting question, which is it's an implant supported 3-unit bridge, and the question is about both screws comes loose. Any potential idea of causes of why this might be happening? Not just for Ghada, but for the rest of the table too, because we sometimes have to sort of think sometimes maybe even outside the box what might be some causes.
I think most commonly, if there is a misfit at the impression aspect of the manufacturing, so sometimes the abutments might not be fitting very well on one of the implants, and that will create an excessive load on both of them and lead to screw loosening. If that happens, then I would recommend that you take a new impression of the pickup impression, splint it, re-pour the model, and then fit that bridge directly on that model and see if there is any issues with the fit. The other aspect is what Agnes talked about in terms of the buckle, the occlusal platform of the bridge, and also laterocrusive movement guidance on interferences on that, especially in the posterior aspect.
And I find often when the patient presents to you with a loosened prosthesis, it is not uncommon that both screws seem loosened at that time, or even with a prosthesis that has, say, 4 or 5 units with 3 screws where 2 are now loose, and just hold on to one implant, but enough for them to feel the prosthetic looseness. But the chronological event is could be that one screw begin to come loose, and then as that one end is more loose, it then now the force is transferred to both, resulting in the eventual both screw becoming loose, or even one is loose and one's broken, quite commonly. So it's just the point of when you see the problem or the patient presents with the problem is both screw being loose.
Yeah, absolutely. Especially as soon as the word bridge is mentioned, how is that impression taken? Was it splintered, etc., etc. So quite often, I mean, just to sum up this evening, whenever we're being faced with mechanical based problems, there's a whole host again of factors that we've introduced tonight. But your diagnostic methodology in troubleshooting, sometimes it is a little bit more tricky because it ranges from patient-related factors, and Johnson spoke about dental parafunction and compliance, what they do. A lot of times they don't even know what they do at home, and of course we don't go home with the patient, so we couldn't figure out either. Occlusal factors that Agnes has explained in detail, laboratory factors that Ghada has covered. There are other whole host of prosthetic related factors too. It was even genuine componentry that was used. So, and how was designed, how experienced is the lab that designed them. So I think you just have to work this through methodically in covering all potential aspects while trying to troubleshoot why something is happening, especially if it's something happening repetitively. Because if we simply just repair that chipped porcelain, polish it, or just keep on retightening the abutment screw, like the whole panel has discussed tonight, the next complication may not be as simple as an easy complication to repair. So before we finish off this evening, any if there's one take-home message that you would like our audience to have tonight, Agnes, what might that be?
Can I say more than one? I was gonna just mention to hone in on the explanation that implant tooth replacement is it's a form of replacement, and it's almost like a user manual, so they can appreciate the differences and how to enjoy it appropriately, so that they can minimize these. But the tool of the hip, may I add? Of course. Is actually it just comes into mind that when there are retainers or rigid splint that are made around implant, more and more I have seen is that if the undercuts are not blocked out well, and the retainers actually engaging too much around the implant prosthesis, and as the patient click in and out, and there's a lot of lateral torque on these implants, and also possibly when they're actually bruxing on it, that it actually flexes about, and it also comes into the notion of you mentioning when you do see peri-implant mucositis, even if the prosthesis can be retrievable, then take it off and have a look, because sometimes you may not see any issues of your crown superficially, but when you go to remove it, if the collar design is quite thin, then we do sometimes see that actually there are some crack lines along this collar aspect that may contribute to the peri-mucositis and things like that as well. So just be mindful of any possible lateral forces.
Absolutely.
As you provide splints and retainers.
For sure. Great idea. And how about you, Ghada?
For me, I think the success of the implant therapy that we provide have to rely on both factors, biological and mechanical. So we have to control biology, control oral hygiene, systemic conditions and all that, but we also have to control the mechanics and the occlusal design for the overall success. You can have a healthy mouth, but a terrible bruxer, it will still fail.
Absolutely.
And then you would have a patient who does not brux as much, and then you have periodontitis around the implant, it will fail. So it's a lot of work before placing the implant and long term after placing the implant, controlling those factors.
Absolutely. Same thing can be said about any form of dental rehabilitation. It's both biologically and mechanically. Zoe?
Well, I think it's important to remember that a lot of our success relies on the patient.
Yes.
And their ability to manage their restoration. So 100% recall these patients on regular basis, establish that rapport with them to help them and educate about the importance of maintaining good oral hygiene, review all these steps along the way. The person might come back and having issues, life issues, and they neglected their teeth thinking everything is okay. So that's why we have to have a recheck of the occlusion,
100%.
Ability to clean, and compliance with the occlusal splint to prevent any of these issues that can happen.
Absolutely. The best form of dentistry can fall to bits very quickly.
It's preventative.
Yeah. Johnson?
Yeah. How do you find, if the technician, once their resistance is over, if they can send you the design before they proceed, that's the best ever decision, or best ever step that
communication
with the lab,
yes.
whether it's profile or size of the tooth. Because before then we spend a lot of time in training and profile. For example, for bruxer with plenty of gum, we want the abutment to be thick enough to resist fracture, right?
Yes.
And then, we thought, wow, finally we're getting it every time. But once in a while, they reduce on all the cases.
Yes.
Suddenly we call up and say,
on?
what's going on? He said, oh, one of the other dentists complained. And I literally say, if a customer say your steak is overcooked, right? You don't suddenly undercook my steak, right? And yet they don't get it.
Right.
And we still get it now and again, right? And then yet the color, contact, occlusion is good, and you send back to remake because of profile.
Absolutely.
But once we ask them to send us the design, everything's good.
In other words, designing implant prosthesis often is collaborative. It's not from just one ideology.
Yes.
I mean, even in terms of this emergence profile.
Yes.
I mean, there's still emerging data
yes.
about what is the ideal angle.
Yeah,
is it
correct.
30? Is it 40? Right? We're still not exactly 100% sure.
For sure.
But anyway, it's good to have an open platform that the whole entire team can collaboratively work on these cases.
100%.
So once again, thank you for the entire panel for your time. Thank you, Zoe, for stepping in the last minute. Thank you, Agnes, for coming in despite having Agnes' daughter just had surgery today. So I'm glad everything went well. So thank you for joining us. That's I really appreciate everything. And thank you, ladies and gentlemen, for joining us this evening. We had a great time sharing what we learned, the heartaches, the pain, the tears over the years, and we hope that tonight's presentation has been helpful. Once again, a reminder for your CBD certificate, please scroll down to the bottom of the page, enter your email address if you want to receive a CBD certificate. And once again, on behalf of the entire group, thank you for our referring dentist for your trust in us. So take care, have a good evening, and hope to catch you next time.